Thank you for joining us today at the ATBH 10 Altogether Better Health Reinvented webinar series. My name is Ala Lawaisi. I'm the Assistant Dean for Student Affairs at the College of Pharmacy, and I'm chairing the IPE program at Qatar University. And moderating the session with me today is Dr. Susan Waller from the College of Medicine and Health Sciences at the United Arab Emirates. Dr. Susan, would you like to introduce yourself, your background?
Yeah, thank you very much, Ala. It's lovely to be with you today, and welcome to everybody. As Ala said, I'm working with the Department of Medical Education at the UAE, United Arab Emirates University, and I'm a very passionate interprofessional education person, having had wonderful experiences in my own country at Monash University and the University of Queensland, and very passionate about learning and working together. So really looking forward to the sessions today and wishing all the speakers well. And thanks very much, everyone, for joining us. Look forward to our discussion.
Thank you, Dr. Susan. This has been hosted by Qatar University QU Health. QU Health is an umbrella of the four different healthcare colleges: College of Pharmacy, College of Health Science, College of Medicine, and College of Dental Medicine. And QU Health aims to, or their vision to be recognized regionally for excellence in interprofessional health education, interdisciplinary health research, a first choice for student and scholar, and a national catalyst for innovation in the field. And just to give you some information about interprofessional.global, their website is their address. So you can, if you can access it through just you write interprofessional.global. It's a global confederation for interprofessional education and collaborative practice. And the vision of interprofessional.global is better health for all through interprofessional education, practice, and research. And the mission is for all of us to serve as agent of change, providing global leadership in advocating for collaborating on promoting, developing, and researching interprofessional education and collaborative practice. And there are various regional networks around the globe, as you can see in different regions, very active networks. The Arabic-speaking network, it is an emerging network at the moment. And we've had our first meeting a couple of weeks ago, and that was the first meeting for the Arabic-speaking countries in the Middle East. You are more than welcome to join, and if you are interested in joining the Arabic-speaking network, you can email us at ipic@qu.edu.qa. And this is also done in collaboration with the established network of the Indian Interprofessional Education Network. So just to give you some background about the ATBHX Reinvented webinar series, some of you may know that the Altogether Better Health 10 was meant to be hosted in Qatar in 2020. And unfortunately, nobody have ever thought at that time that COVID is going to hit us all, unfortunately, which led to the postponement of the conference until 2023. And as a result, many of the accepted abstracts for the conference, we've communicated with the speakers, to see if they are interested in presenting them in the ATBH Reinvented webinar. And as I mentioned, there are various networks around the globe. So the regional and the emerging networks of interprofessional.global have been working collaboratively to come up with seminar series. That's why we have number 7, which is today, and then number 8 next week. In total, there is a 25 presentation, and you can access the book of abstract on the interprofessional.global website. For your information, the presentation will be recorded and posted on the interprofessional.global website at the conclusion of the webinar series. Session 7 and 8 will also be available on the Qatar University YouTube channel, and we will share these with you later on. And this is the link for the, if you would like to get to access the book of abstract for this webinar series. And after the end of the webinar series, it's going to continue as virtual, the virtual cafe. So almost every month there is going to be an IPE collaborative practice presentation from different parts of the world. And I know that they're really working hard on coming up with a very nice program. So for today's session, we have some very exciting presentation. I'm personally, and I'm sure many of you are looking forward. And so to get started, without further ado, or actually before we get started, speakers will have around 20 minutes. So each presenter will have a total of 20 minutes for their presentation. If any of the presenters take a little bit more time, or they finish early, they have a total of 30 minutes for their part. If they finish early, there is an opportunity to ask some questions, or we will hold most of the questions until the end of the session, and both myself and Dr. Suzanne will be reading the questions. Or if you're not typing your question within the chat box, you can raise your hand and you can speak to us directly. So there are two options for this. So without further ado, I'm going to introduce our first speaker, Dr. Mohammed Arsalan Zamir. He is a Deputy Physician Lead and Consultant Family Medicine at the Primary Healthcare Corporation in Qatar. And he's going, very much looking forward to his presentation, Team Talk, a Healthy Way to Talk. Some background information about Dr. Zamir. He works with the Primary Healthcare Corporation in Al-Wajba Health Center as a Deputy Physician Lead and a Consultant Family Medicine. He completed his undergraduate study at the Imperial College in the UK in 2005, and then qualified in Family Medicine from London in 2010. He has a wide range of experiences in different primary care settings, and he has also developed postgraduate interest in sport and exercise medicine and lifestyle medicine, along with passion for innovative quality improvement and interprofessional collaboration. He was recently awarded fellowship by the Royal College Practitioners in the UK and an associate fellowship by the Faculty of Medical Leadership and Management in UK for recognition of his skills, experiences, and achievement in family medicine, leadership, and management. Congratulations, Dr. Mohammed. Away from work, he's a father of 3 and enjoy an active lifestyle through playing badminton, squash, and golf. Dr. Mohammed, the mic is yours.
Thank you very much indeed, Dr. Ala, Dr. Susan, and also Zaina. Just start sharing my presentation. So first of all, just a big thanks again for coordinating this webinar and for inviting me to talk. Specific thanks to Qatar University, Altogether Better Health, and Interprofessional Global. So the topic of my presentation is Teamwalk, a healthier way to talk. And I'll guide you through what was a quality improvement initiative at Al-Wajba Health Center. So as we work through the presentation, on the left side, you can just track the progress. So first of all, I set some background scene. I'll talk about why it's an innovative quality improvement project, how we implemented it, so the nuts and bolts and the nitty-gritty of the project, and then also some details about the results and our findings. So first of all, no conflict of interest to declare in terms of this presentation. So let's start with some background. So back in 2010, the World Health Organization published a framework for patient safety, and this specifically underlined the importance of interprofessional collaboration. And they linked this with improving health outcomes. And one of the things they suggested was to have team meetings on a regular basis. And this would have the benefits of enhancing working culture as well as shared decision making. Looking wider at the literature, Dingley et al. A few years ago talked about collaborative communication and also talked about the positive impacts that this sort of communication can have on patient safety and outcomes. They suggest team huddles as an option for something quick and functional in terms of having an interdisciplinary meeting. A systematic review by Buljach and Samardic later on, 2020, talked about improving team functioning. Again, the theme of collaboration and the theme of interdisciplinary meetings. So this gives us a little bit of background literature information as to where we're headed. Now, at Wajba Health Centre, which is one of 28 health centres that come under Primary Healthcare Corporation in Qatar, we had a patient safety culture survey conducted across all the health centres. And when we reflected on the results of this survey at Wajba Health Centre, we felt that there were some domains that we could further improve on. And these were specifically communication openness, teamwork within departments, as well as across departments, and also organizational learning and continual improvement. So what we thought that we wanted to do was initiate a quality improvement project. And this was going to be something that was innovative. It would address teamwork communication as well as organizational learning domains, the ones that had been identified in the results of the survey. We also thought that actually to add an extra element to it, we wanted to try and address a very common theme of sedentary work patterns, which is a public health concern, not just in the workplace, but also in the wider public. So we came up with the idea of the team walk. And so this was an innovative style of professional collaboration amongst interdisciplinary departments. We wanted to enhance teamwork and improve the culture of patient safety at our health centre. Now, when we talk about collaborative meetings interprofessionally, things that come to mind straight away are the constraints of a specific time, a specific venue, getting people together. So what we thought was that we'd have just a very brief 15-minute walk at the end of each week. We'd gather physicians and departmental leads, where the walk would start at one end of the health centre. We'd invite colleagues from different clinics as well to join the walk, and then we'd culminate with a standing meeting, and this meeting would then be minuted, and these brief minutes would be emailed to our staff. So what you can see in the top right is Wajba Health Centre. So this is in the western region of Doha. Not sure whether it projects very well, but we have quite a large health centre here. It's almost akin to a mini hospital, actually. So we have quite a large waiting hall. We have quite nice wide corridors. So we thought that we utilize this space and walk within this open space and the corridors as part of our team walk. So what were the overall and overarching objectives? We wanted to introduce and embed the team walk as an innovative style of interprofessional collaboration at Wajba Health Centre. We wanted to conduct at least 2 team walks per month because we have a shift system, so there are 2 teams. So we wanted to capture both teams. And specifically, we targeted at a 30% improvement in the domains of teamwork and communication openness. So the team walks were conducted over 3 months as part of our project timeline. Physicians and departmental leads were invited. As mentioned, the minutes were emailed, and these were very succinct minutes that we put together. And then we distributed an anonymous qualitative survey. So here on the right, you can just see a little snapshot of a very recent team walk meeting, actually. So just, as typical minutes are put together, discussion items, we always try and start with some good news and some positive feedback to start on a high note. If there's some interprofessional aspects of the discussion, we go with that, and then we focus on each department turn by turn. So this was the actual survey that we distributed once we had completed 3 months of team walks. So we're looking at the 4 domains of teamwork within departments, teamwork across departments, organizational learning, and then communication openness, and just specific descriptors within these 4 domains. And happily, these were the results that we got. So this is looking at change from baseline, starting in January 2020, and then up to April in 2020. So I'm not sure whether it projects very well, but the bold outlined results, so teamwork within departments, organizational learning, communication openness, and teamwork across departments, all showed at least a 60% improvement. So where we were aiming for 30% improvement in these domains, we had an overall 60%, minimum 60% improvement. And then with each descriptor, you can see the specific changes. So the greens were the change in improvement. As you will recall from the survey, we had a section for our participants to provide some written feedback. And just using a little word cloud and bubble presentation, these are some of the key themes that we came up with. So, the forum for highlighting concerns, the option to connect with colleagues, interprofessional collaboration was obviously there, empowerment for staff members, improving communication, positivity, having a discussion forum, the exercise component as well. So we were really very happy that actually these were the themes that people were subjectively putting across to us. So in summary, our teamwork has been a successful time-efficient innovation in interprofessional collaboration. We had more than 50% improvement in the teamwork, communication, organizational learning domains, and we had benefits for patient safety as well as the additional bonus of having staff health benefits. Obviously, these weren't actually quantitatively measured, but certainly subjectively, these were reported to us. So we deem this to be a sustainable quality improvement project at the health center. And you would have noted from the minutes that I showed earlier on, these team walks are actually continuing even regularly. So even as recent as this month, we had our most recent team walk. So it's become a regular fortnightly fixture at the health center, which we're very, very proud of. So just to finish off on the references that I had alluded to earlier on, the World Health Organization, Dingley et al. And Buljat Samardic. So that concludes my presentation.
Thank you so much, Dr. Mohammed. This is really, really interesting. Having teamworks. Anyone would like to ask a question? Please feel free to.
I have a question.
Yes, please, Dr. Sita.
Yes, thank you, Dr. Mohammed. This is very interesting presentation and hearing about the dynamics of how the PHCC works. My question is related to when the COVID hit us and we have all these restrictions. How did the IPE walk or the team walk took place when no access to the physical PHCC? What are the challenges that you faced to implement this team walk?
Yeah, that's a very pertinent question because when we had thought of the project back in January 2020, nobody knew that COVID-19 was going to hit us so hard. So actually, we were in the midst of the QI project when COVID-19 pandemic hit us. And obviously early on, when there was a lot of uncertainty about protocols and how we were going to conduct ourselves, there was still the team collaboration, but not the walking aspect of it. So what we had was MS Teams, and we had regular meetings on MS Teams, which is the virtual meeting platform that we use at PHCC. And rest assured that the walks that we had done, the team walks, they were very, very sorely missed by all the colleagues that have been participating. So given the first opportunity, when we realized that actually with social distancing, obviously, and taking precautionary measures, that we could resume, we did actually resume. But yeah, it was a big hit to us from this aspect. Yeah.
Thank you.
Yeah, Dr. Taysir. I think, Zaina, if you can unmute Dr. Taysir.
Thank you very much. I really, really enjoyed the presentation and the innovation within PHDCC. So my question would be, how did you coming to those walk was something popular, like people, how many participants, and how did you actually get them to do that? Because it's not something within the culture. It's amazing, but I was just wondering, how did you get that popular?
Yeah, it's a good question actually, because it wasn't all smooth sailing, as you can expect. Because when you try and do something innovative and outside the box, invariably it's human nature to think of, let's say, the negative aspects possibly, the constraints possibly. So we were having team meetings within the physicians department anyway from time to time. And we felt that the background to it, obviously getting people together was one issue. So we used that as a convincing tool to say, well, actually getting together in one specific time and venue is not easy. Towards the end of the clinic, we're all wanting to look for a little bit of a break and have a bit of a breather. So presenting all the positive aspects. And yes, people did say, well, actually, you know what is this standing meeting all about and why are we walking? And so, you know, that was entirely expected. But once we had participants, which, you know, ranged anywhere between sort of a handful, depending on the clinics, depending on the busy schedule, even up to sort of 20 to 25 people, you know, we had a lot of buy-in once that got going. And those colleagues maybe that were a little bit maybe circumspect at the beginning, bought in very nicely, and you know, it's become part of our sort of fortnightly fixture now, and so there aren't any questions because people know that actually it's something that's working and working well. And many of those colleagues that were maybe circumspect, you would say that actually for them there was this forum to be able to highlight any you know, key points in the week, any concerns, and discuss them. So thankfully we found that the overarching positives of it far outweighed the initial circumspection.
Well done. And no food involved, so well done.
Thank you. Any other questions?
Yes. So it's a great initiative. Also, you know, like people being active. I was wondering, did you manage to, you know, share that experience with the other primary healthcare centers, or is it still only something that only people in Al-Wajda are aware of?
So yeah, at PHCC, when we're doing a quality improvement project, it is something that you initially need to put the proposal in. It gets approved by the Quality Improvement Clinical Affairs Directorate. So centrally, PHCC management are aware of it. We've then tried, obviously, again, in the backdrop of COVID-19, and each health center has its own nuances. So not all of them are the fortunate size that we have at Wajda. So this is one of the newer builds from 2018. So some of the older health centers don't have that facility of obviously having the space and the capacity to be able to do the walks around the health center. But yeah, certainly it is something that PHCC Quality Improvement Directorate, they're aware of, and hopefully, given the time and tending back towards normal pattern of work, we can hopefully try and get this cascaded across PHCC.
Excellent. Elizabeth?
Can you unmute yourself, Elizabeth? I'm sending you a request to unmute.
Elizabeth?
You can unmute yourself.
Okay. Can you hear me now? I'm
Yes,
sorry.
we can.
All right. You said, thank you for this inspiring talk. You said also the safety for patients got better. So how did you measure this, or how did you realize this?
Yeah, I probably should clarify. I didn't quite specifically say that the patient safety got better because we didn't directly measure that. So what we had looked at was the patient safety culture survey results from the staff that had undertaken the survey. So we looked at the domains that we thought we could try and improve on. So the next survey hasn't yet been done. So when that survey is done, hopefully we can see a translation of improvement in those domains. But by proxy, this forum gives staff the opportunity to raise concerns, discuss DATEX incidents, for example. We can do a brief, quick review amongst the team members. So although we don't have hard data to say that, yes, we've made an impact on patient safety directly, certainly we're confident that there are adjuncts and proxies to say that certainly this should hopefully translate into a more safe environment for patients.
Okay, thank you.
Thank you very much.
Thank you. Suzanne?
Yes, I just wanted to congratulate you and your team, Dr. Mohammed, on a really interesting evaluation. Obviously, a lot of thought went into that, and it probably was there in the evaluation. But I just wondered for yourself, your perception of things. Did you find that with the walk before the standing meeting, that there was it stimulated greater interaction and collaboration in the meeting?
Absolutely, yeah. That's you know, a very, very important point, because colleagues, once these meetings got going and we had a schedule and a routine, colleagues were looking forward to the fact that not only would they be able to stretch their legs after such a long you know, session in clinic, but also they'd see colleagues and connect with them, which they hadn't seen maybe even for a whole week or 10 days sometimes, you know, because of different shift patterns, and obviously being very busy in clinic, you don't often have that time to be able to, you know, step out and meet your colleagues and connect with them. So yeah, absolutely. This was something that we found was a huge overpowering positive. And when for some reason we weren't having the teamwork, people would ask us, you know, what happened to the teamwork this week? We didn't have it because obviously there are other commitments going on. But yeah, you're right. They would look forward to it. You know, they'd get the knock on the door at 1:30, and they knew why that knock was, and join us very, very happily.
Excellent. Dr. Mohammed, like, were there any challenges? Maybe just going back to Taysir's question, is, you know, having that culture of people wanting to conduct these meetings, you know, while walking. Did you face any kind of resistance, any kind of challenges?
Yeah, so I alluded to one of the challenges, which was the fact that it was a new idea, and people were really sort of raising their eyebrows at the fact that we were doing a walking meeting. What does that mean? You know, why can't we just sit down and talk? So that was the first challenge. The second challenge mainly, and even it's now a challenge as well, actually, but it's a nice challenge in a way. It's the fact that we have limited time, so we want it to, you know, by purpose, be very brief and be very to the point. So it's almost like a very bullet pointed meeting, but sometimes there are issues that will take a little bit more time to discuss. So what we try and then do is try and allocate separate time, whether that's you know a routine sitting meeting or a one-to-one discussion. So we try and allocate separate time for that. But in the context of the team walk, where we want it just to be sort of 15-20 minutes, you know, it is a challenge to cram everything in that people want to talk about. But that's a positive, because you know it's suggesting to us that there are issues that people need to discuss amongst us as a team.
And like, what kind, like, for example, if you are to improve these team walks, any kind of suggestions, recommendations that you would suggest?
For us at Wajba Health Center, is that the question, or generally if people wanted to try and implement these in their work setting?
Yeah, like in Al Wajba Health Center and also in other settings as well.
Yeah, ideally we'd love to do them more often, to be honest. That would be an ideal. The more often you can do these, you know, the more healthy hopefully you can get. We don't have the measures for the health improvements, but that's something we could try and track as well, using health data. We know generally that sedentary behavior, obviously there are lots of links obviously to chronic disease. So we know that just by being, you know, active and walking, even if it's not to a high exertional level, should be of benefit. But yeah, we'd love to do more of them if we had the opportunity and the time. But obviously, with the constraints of work in the public healthcare sector, it's not easily possible.
Excellent. I'm just like thinking, like, for example, with students, healthcare students, or, you know, even students within the colleges, you know, having to introduce this, I think, you know, would be really something interesting. And I'm sure students would really enjoy it. Like, let's say faculty students working together, healthcare students working together. So thank you for your inspiring speech. It got me thinking.
Oh, absolutely. And the walking aspect that we do as we gather the colleagues around the health center, actually that component of it, we felt that we'd keep it social. It's not work chat. So actually they get together and they say, oh, you know, how was your week, or how was your clinic? And so it's a bit of a social chat. By the time we get to the standing component, that's when obviously then we come up with the nuts and bolts of the actual important work related issues. So yeah, that there is the social element of it as well. But yeah, thank you very much.
Great. Dr. Anthony has a comment here. I appreciate the connectivity of such activity. It provides the opportunity to move beyond structure for more organic learning. Thank you, Tony. Okay, so thank you once again. We really appreciate you taking the time to join us. And there is going to be an opportunity at the end if anyone have any question, you know, they can ask as well. Okay, so our next speaker, we have Professor Guillaume Eleanor. He's Director of Research at Hamad Medical Corporation, Ambulance Services, and an Adjunct Professor of Education in Medicine at Weill Cornell Medicine, Qatar. Professor Guillaume moved to Qatar in 2011 and joined HMC Ambulance Services in 2013, where he is the Director of Research. After his undergraduate studies in France, he moved to the UK to obtain a Master of Applied Physics and PhD in Simulation in Healthcare Education. He started his academic career 20 years ago at the University of Hertfordshire in the UK. He also holds the position of Adjunct Professor at Weill Cornell and is a visiting fellow at Northumbria University in Newcastle upon in the UK since 2009. He is the recipient of a National Teaching Fellowship Award from the UK Higher Education Academy, now known as Advanced HE, since 2006, for his work in developing educator and enhancing student learning experience through interprofessional simulation. And he has recently published a book on debriefing with Professor Dennis, which has been translated in different languages by Springer and Elsevier. It's a real pleasure to have you with us, Professor Guillaume. And I'm always interested and fascinated by the simulation work that you have been doing. So the mic is yours.
Thank you. Just going to try and share my slides now. So I'm not going to talk about simulation today. It's other project I'm going to cover. And now you should have my slides, hopefully. Can you see my slides?
Not yet.
Sorry, I just need to press share. So thank you for selecting our submission for presentation in this webinar.
Still, we cannot see the slide.
It's coming up, it's turning, it's coming now. So thank you again for selecting our project. Work I've been doing with many colleagues, you will see later on, but my co-authors on that presentation are Jim, Beverly, and Dr. Lua, our medical director in the ambulance service. So it's about undertaking project as a multidisciplinary team-based activity to learn about quality improvement science in healthcare. So an activity which is ongoing at HMC and in which the ambulance service has been lucky enough to take part on a number of occasions. So this is the outline of my presentation, giving some context. I believe this being a webinar, I think some people are outside of Qatar, so I'll give an overview of this context here locally. Talk a little bit about science of quality improvement, HMC quality improvement educational program, the participation of the ambulance service with examples of projects, how it has benefited patient care, some of the scholarly outputs I'm aware of, and some general conclusions about our participation in these projects. So about Qatar. Qatar is, a country, I remember being very young, I had a map of the world. I still have that map. It's in one of my boys' bedroom now. The map is dated around 1980, and the population of Qatar at that time was about 80,000 people. So Qatar is a country that has grown, at an incredible pace, as you can see in this graph, now at about 2.9 million. And you can guess, the impact is that it has had on the healthcare system as well. So we're based in the Middle East, highly reliant on an expat population, male expat population, especially since 2010, announcement of hosting the World Cup next year. So you can see also the disproportionate amount of male in comparison to ladies in Qatar. In terms of the healthcare sector, back in 1957, Rumaila Hospital was the first hospital opened, and there was a few health centers. Population was mainly in Doha and Wakra, and now we have 28 primary healthcare centers, 12 public hospitals, several private hospitals, and many polyclinics. Of importance as well is the Qatar National Vision. Big aspect is people development, and I'm going to go into the quality improvement aspect in the next slides. But this is really guiding how healthcare is developing in the country, and is quite an exciting journey. So regarding the science of quality improvement, this is directly from the Institute of Healthcare Improvement website. The science of improvement is an applied science that emphasizes innovation, rapid cycle testing in the field, the spread in order to generate learning about what changes, in which context, produce improvements. Sorry. It is characterized by the combination of expert subject knowledge with improvement methods and tools, which I will briefly explain in the next slide. So these are some of the commonly used tools that are used in quality improvement projects. Key to it is knowing the context, identifying an issue that you're trying to fix, getting some data about it, brainstorming with the team, looking at what are the possible causes and effects and how it can be overcome, looking at the current process map of the situation you're analyzing, getting more data, doing your control charts, implementing cycles with interventions, collecting more data, and again seeing if you are improving the situation. So obviously key to it are the PDCA or Pdca cycles, known as the Deming cycle, the Short cycle, where you constantly plan, do, study, act on what you're doing, and you repeat it multiple times until you see what are the most critical interventions you can do to improve the process you're working on. And we're doing this in the context of healthcare. So at HMC, we've got the Hamad Healthcare Quality Institute. In fact, it's also open to other institutions. So we've had colleagues from PHCC and from other institutions also engaging in some of these activities. So the HHQI had a number of programs. I'm only going to concentrate on the CCITP program. Also, we've had staff taking part in some of the others and becoming fellow and so on. But CCITP really touches a large population. Even at a largest population would be the Middle East Forum for Quality and Healthcare, which was only last weekend, which is kind of the foundation level in that pyramid, accessible to all staff as an online conference. But to which we encourage teams who do the CCITP program or other programs to submit posters for sharing their experience. So the strategic goals of FHQI are here, the mission and the vision. So the vision is to be a global leader in healthcare quality improvement, and that's why they are partnering with internationally renowned experts from the Institute for Healthcare Improvement. And now let's move on to what we've been doing in the ambulance service. So we've managed to engage staff in multiple cycles of the CCITP program. So CCITP program happens over the course of 9 months. It's module based, so from time to time the staff are invited to attend 2 days of face-to-face workshops. We've had to do it as well online during COVID. Just now we've restarted. In fact, yesterday and today, my colleagues are there at the workshops, learning all about the tools I've presented in the previous slides. They also have assignments they need to decide on their on their own topic they want to study. We also kind of review it locally, us as sponsors agree whether it's a project that is of interest and is going to, really try to solve one of the issues they have identified or that, the leadership has identified as well. So the sponsors and facilities get to put forward their teams, usually 1 or 2 teams. So, our team will be only staff from the ambulance service, but they will be multi-professionals. So we'll make sure that we'll have, a paramedic, maybe a dispatcher, who works in the call center, one of our physicians, one of our nurses who work in home healthcare. So we make it a multidisciplinary team. But once they go to the workshops, like they have today, once every month or once every couple of months, they actually meet people from other teams, which might be, theaters, anesthesia, emergency medicine, and also there they have a multidisciplinary team. So they learn about other projects because they keep on doing presentations to one another, explaining the situation and, brainstorming together. And at the end, they have, a certificate with the CPD points that correspond to the number of hours they've attended for all these sessions. So it could be, over the course of 9 months, like 60 CPD points or, 60 to 70. So it's quite rewarding for the staff as well to get all the CPD points for all the effort they put into the program. So HHQI, in fact, started back in 2010, these CCITP cycles. It's only, I think, in 2013-14 that we managed to start engaging our staff into that. So far, we've engaged staff in 9 projects, totaling 38 staff, and every team was multidisciplinary, including the professions which are mentioned here. So ambulance paramedics, critical care paramedics, emergency medical dispatchers, nurses, family physicians, quality reviewers, and pharmacists. So some project examples. This one was done, 2017. We get a lot of ambulance, a lot of recalls. So, patients are diabetic. They may not know about it, or they may know about it. They get fixed, they feel better, and then they say, I don't want to go to hospital because they don't want to spend time in the ED or anything. But then, maybe a few hours later or the next day, they call us again. And that's, that can be quite a significant number of patients that, maybe 10% or more of the patients who refuse transport to hospital end up calling us again. We fix them, and then they call us again, and they are regular patients. So we've identified that, or the team has identified that issue. They wanted to have some interventions. They wanted to encourage staff probably to deliver some, not probably, but certainly to deliver some patient education. So to educate the staff about their condition, because at times they may not be aware about it. They haven't been formally diagnosed. They refuse to seek proper help. So we have actually delivered, flyers to them that we got from, the Qatar Diabetic Association, from the center at HMC. So we had several interventions trying to force our staff to educate the patients and trying to reduce the number of recalls. And that's been quite a successful project. It has, huge implications for resources utilization because repeat calls for something that could be, prevented if the patients were, probably better informed, if they knew how to manage their condition. Another example, seatbelts are for everyone. This is about proper patient and staff restraints in the vehicles. Driving vehicles at high speed, either going to a call or returning to the hospital with the patient, is prone to us having accidents. So we want to make sure that everybody's safe. So it was, again, having reminders, having staff collecting data, raising awareness as to expectations and so on. This is a project that was completed, I think, in 2019 and was presented at the Middle East Forum last week. And still ongoing. A lot of these projects have been given rise to changes in our CPG or clinical practice guidelines, standard operating procedures. There's been memos sent to staff about staff directives sent regarding some of the key things that we've worked on. Project just starting now. This is a fresh picture from this morning that my colleague sent to me. Get the short, understanding vaccination hesitancy in HMC ambulance service. So this is a project that the team is going to engage in over the next few months. So regarding the flu jab, regarding COVID vaccine, and they'll do some questionnaire, get some data, and also see the effect as to the uptake in comparison to data we have historically over the last few years, especially regarding flu. Every minute counts. Another key project that has resulted in some changes. This is the ED turnaround times when our staff need to restock on medicines in the emergency department. Before, we didn't have a pharmacy in the emergency department. They needed to come back to or go to the helipad, which had the pharmacy, or go back to our headquarters, or one of the hubs. And now we've changed the process, and there is ED pharmacy dispensing, ambulance service dispensing directly at the ED. And they looked at, how much time it saved for our vehicle to be again available to go to the next call. And you can see probably in the chart there, that this is the time duration for the ambulance to be made ready again. So it saved us like 15 or 20 minutes. So it makes the vehicle availability of vehicles much more effective. Other examples, making social cleaning happen between patients. So we don't have time to go through deep cleaning all the time, so we expect staff to do some basic cleaning, using disinfectant around the vehicle, on all the equipment they've used on patients. Clinical handover, making sure that handover between paramedics and the ED staff is not interrupted, is complete. We use Admistombo, which is quite similar to SBAR. So we're really trying to educate the staff to do it properly on both sides. So we had collaboration from the emergency department for that project to happen. All eyes on diabetic retinopathy. That was for our home healthcare center, home healthcare service with the mobile doctors. Minimizing interruption during paramedic delivered CPR is another key project that we had, and I think that's the first project we engaged in with CCITP. The ambulance service is capturing an enormous amount of data from the monitors we have, so we can see interruptions, if the CPR is not optimal. We're using Lucas, we're using the electrodes to monitor also the chest compressions. And these are some of the slides from the colleagues at the time when they presented. So a good experience from the staff because they get to present. So they develop skills, presentation skills. They develop, assertiveness as they are implementing their project, communicate with other colleagues to collect data and so on. So these are, some of the areas, or in fact, these are the possible areas where we can try and improve the patient care. And the project I've mentioned, you can see them how they fit in different areas. Patient family engagement when we do diabetic patient education through our staff. Support services equipment, maybe for restocking the drugs and other supplies in the vehicles. How that has changed. So other lessons learned. It's been fantastic because the staff can select their own project. And then we kind of prove it. So there is a great sense of ownership of the project. So it really motivates the staff to work hard. They are driving the change. It's better than the top-down approach because they are the one who are making the suggestions to improve how things are done. So it's been a great staff development experience. They learn about the science of quality improvement. So even at times there is not an official project, they'll come up to my office and propose to do a small research study that in fact could become a quality improvement project. They also understand the value of proper documentation. Some of my intervention with staff when we recruit new staff being into research, and at times we make use of secondary data, it's very important that everything they do, they document it properly and fully, so that we can exploit the data. And they realize for some of their QI project, when they need to use retrospective data, they realize the gaps. So they realize then the importance from now on to to document everything properly, so they can exploit it. So it can be exploited in the future by other staff who will do projects. Has had a direct positive contribution to the organization in general, improving the effectiveness of our service and improving patient care. Definitely. And also, when they do the brainstorming and analyze the issue, it really forces them to consider the patient perspective. Also, because they are working from a multidisciplinary team, they get different perspective, from people who are probably less biased because they haven't been used to working that way the whole time. They discover a new area, so that you can have a fresh suggestion from someone who is otherwise working, as an emergency medical dispatcher, or maybe someone who is a paramedic and will make suggestion to people who take the calls, the 999 calls. So it really contributed to breaking organizational silos. The ambulance service is not just the ambulance service. We've got several services, support services, emergency, transfer and retrieval, patient transport service. We also have some physicians who work in special ops and nurses as well. So really the multidisciplinary team aspect, has provided a different lens to the issues that were, analyzed and trying to be fixed, and also, provided at times innovative solutions. These are, just some of the, presentation I've been given at different conferences, mostly in Qatar, and there are some journal articles which have been submitted, and hopefully some will be accepted quite soon. So just to conclude, the senior leadership of the ambulance service is very supportive of the CCITP project, even if it has some impact in terms of releasing staff, to attend the training days. We work around the schedules to allow them to attend all the sessions they need to attend. A fantastic staff engagement. All the staff that have, we put out a call, like I will send out a staff circular inviting for expression of interest. Then we'll select among the people who propose themselves to be engaged in CCITP project. And then these staff, you can see them in fact developing faster than the staff who maybe would be shy to engage in the project. So it's been a fantastic development opportunity for the staff who've gone through it. They realize that data is key. We have a lot of data, but the data is only as valuable as it's valid, and that we make good use of it. We need to have interesting projects to exploit that data so it can inform what we're doing. We have good impact of the project on patient care. Many SOPs and CPGs have been updated based on that, because we realize maybe there's gaps. It's not clear enough at times in our standard operating procedure how the patients need to be restrained on the stretcher. So we need to be more specific. Also, for example, using the shoulder straps. That's one very recent amendment to one of the SOPs. And everything is evidence-based. So it's not just opinion. We have data to support and back up why we are requesting changes to some of these key documents. Thank you. I hope it has given you some flavors as to the type of CCITP project we've been doing, and we'll welcome some questions now or later.
Thank you so much, Dr. Guillaume, for this really great presentation. I was really impressed by the variety of the different projects, touching on various aspects. This was really excellent. Thank you. Any questions? Dr. Suzanne.
Thanks, Dr. Guillaume. Yes, as Ala said, that was amazing. You can really see the dynamism of the service with all those wonderful projects happening and improvements that have come as a result of those. I just wanted to ask you, if you took off your quality improvement hat and put on your interprofessional educator hat, what is it about the area of patient safety and quality improvement that does support collaboration, do you think?
So which hat do I have to have on? The educator or the quality improvement?
Interprofessional educator, yeah.
And the question is?
So I'm thinking, what are the elements of the experience of participating in these projects that supports people in multidisciplinary teams to be more collaborative?
Yeah, I think they just get to understand each other's role much better. Like, for example, the dispatchers who are regularly in contact with staff in the vehicles, they may at times not have had the experience of working in the vehicle and seeing, the pressure and so on, and why it takes them, half an hour maybe to discharge a patient, not to discharge, but to transfer or to hand over a patient in the ED and have some time to just drink a lot of water and go to the loo and repack the vehicle, and on the other side you've got the emergency medical dispatchers, like, you've been there for 20 minutes, we need you on the road, you have calls pending, because they all work together at collecting all the data, when they were looking at turnaround time for the pharmacy and replenishing, they really get to understand each other's role a lot better, and then they discuss and then they share their perspective, and I think they get more respect for each other's contribution to the chain of patient care. So it's fantastic, and we really make an effort to make sure that there is no duplication, and we get staff from different specialty involved each time.
Thank you.
I have a question. Like you talked about like as part of the lessons learned that it contributed to breaking organizational silos. What about professional silos? Did did it have any contribution or that, or like were there any challenges faced with these multidisciplinary projects?
Not that I know of. I think every team has worked very well together. So no, I'm not aware of any problem. I think it's just I think in general, and I've worked with many professions, and I've always found even at the student level, when I was in the UK, the paramedics are probably more kind of outgoing or extrovert, just by the nature of the job, the function they select. So I think they are quite adaptable. Working in the pre-hospital care setting, every call is a different surprise. There is no real routine as such, because you transition constantly between maybe a medical case, a trauma case, a fake case, someone who just wants a break from, working in the heat or something. So yeah, I think that it just give them the exposure and understanding of all type of situations across the professions.
Thank you. Elizabeth, do you have a question?
Yes, thank you for the great speech and for this great opportunity for the people to get to know each other, because I think this is so important for caring for people. My question is, how do you approach the people in the first place to participate in this program? And how do you set up the teams then?
Yeah, so we get informed by HHQI that there will be a cycle starting, within a few weeks, and they give us a deadline by which we need to put forward a team. So immediately we'll, send out a circular to staff with a small form to fill in, where they, hopefully, usually we try to ask them to come forward with a team already. But at times, we get a form that is only one name. So then we kind of put all the forms together on their project idea and then why they want to do it. And then we form the team. So, and we have, we collect all these names because at times we have more people applying for that program than we have places to offer. So at times, HHQI will tell us this time you can put forward 2 teams, or only 1 team, but we keep track as to who has expressed an interest, and so we try everybody who has expressed an interest, we try and eventually put them through the project. So yeah, usually we have enough people coming forward, and then if there is not enough people coming forward, we still have a pool of people who have expressed in previous cycles, expressed an interest, or at times there is, in some departments, they would like someone to learn more about quality improvement. So we can also ask a department to put forward a member of staff.
Okay, thank you very much. People come already with their own idea for the project then to participate. Is this?
Yes, yeah. Most of the time, they decide on the project because it's something they've identified as an issue. So yeah, very rarely. I think maybe the patient restraint was something that we suggested because we noticed an issue, but all the other projects, they were self-identified issues. Like the patient recalls is something that was not at all on our radar because it's only the staff who are there who realize, we've been called already, earlier in the shift to the same, by the same person, and then they realize, having worked here for a few years, that it might be a regular pattern. So let's look at that as a project idea, and then we, use. We've got a business intelligence department who hold all the data, and then we started to look at, can you tell us, over a period of 24 hours, 38 hours, if there's been any refusal to transport, and then again a call to the same address, and then we've seen that we've been able to find out how many times it happened, and trying to address the issue.
Okay, great. Just have one last question before we hand the mic to Dr. Susu. Do staff get any kind of incentive for participating within these projects?
I think the big incentive is the certificate, to be recognized as a champion for quality improvement projects. They get all these CPD points, which probably meets their quota for the year, and also something which breaks out the routine. If they are regular ambulance paramedics or emergency medical dispatcher, week in, week out, it's the same rota. I mean, they respond to different cases, but it's them going on duty in the field or in the National Command Center. Whereas this is like a CPD activity where from time to time they get a day off working in the ambulance or in the dispatch center, and they actually go to our club hotel and have these educational seminars and group activities. They also are informed that it requires a lot more work outside of their, when they're on shift, they cannot work on the project as such. So when they need to collect data is in their personal time. So they also make a promise to, for the project to work, that they need to invest their personal time into it. Because it's not something they can do. Most of the time, it's not something, they cannot stand while on duty. They cannot spend, 4 or 5 hours in the emergency department looking at, the turnaround time. They cannot do it. They cannot do it during their shift. They need to do it after work on a day off. So that's something that they also need to accept.
Excellent. Thank you so much, Dr. Guillaume. And there is going to be opportunity to ask Dr. Guillaume any questions later on. Okay, so just sharing my slides again. Okay, so our next speaker is Dr. Susu Ghayer, Associate Professor of Microbiology and Immunology at the College of Medicine at Qatar University. And she's going to be talking about the immunization program that it requires interprofessional team to sustain high vaccine coverage and community protection, a very interesting topic. So Dr. Susu, she was trained as a clinical microbiologist at the University College London. She got her MSc and PhD in microbiology and immunology from Cardiff University in the UK, and did her postdoc training at Harvard Medical School in Boston, USA, and was also the assistant professor of microbiology and immunology at the Moroy University School of Medicine at Atlanta, USA. Her research is focused on host pathogen interaction, vaccine development, and nanotechnology for rapid detection of bacterial infections. Her translational research is focused on vitamin D immune modularity effect, and she implements artificial intelligence in medical application in her research. She has more than 60 scientific research papers and was awarded 2 patents on her discoveries. She has been listed among the top 2% of highly cited authors with impact in their field in 2020 Stanford study. She is an active member of various international societies and served as an associate editor in the editorial board member and an ad hoc reviewer for multiple international journals. And Dr. Susu is also an active participant of our interprofessional education activities at Qatar University. And last year, she did an IPE activity for our healthcare student on COVID hesitancy. So welcome, Dr. Susu, the mic is yours.
Thank you. Thank you very much for the introduction, and thank you very much for inviting me to participate in this webinar. So I hope you could see my slides. As Dr. Ella said, I'll be taking you through a discussion actually on the role of interprofessional team in implementing protection in the community by maintaining the vaccine coverage and enhancing the vaccine uptake. Let me move my slides. All right. So why do we need vaccines? I guess by now the word vaccine has been used more than ever because of COVID. But if we look at the historical data, 100 years ago, we had the 1918 Spanish flu pandemic. And if you look at the all cause of mortality, you could see the spike because of the death associated with the pandemic, the Spanish flu pandemic. You look at the non-communicable, non-infectious diseases mortality rate. Until now, it's still at the same level. But when you look at the infectious diseases mortality rate, yes, we have this spike because of the flu, but then it declines and still very low. This magic is because of the vaccine. The introduction of the vaccines seems to be enhancing human life or increasing the longevity of human life, and managed to control and eradicate certain infections. Like you see here, the smallpox was officially eradicated by the power of vaccines. But as Anthony Fauci said, having vaccines in the vials does not protect anyone at all. It has to be given and administered. So here we introduce the concept of vaccine coverage. And that means the more people are taking the vaccines, the less cases that we would see. The example here shows the pediatric vaccination that we have in most of the countries in the world, tetanus, diphtheria, and polio. And you could see that with increased uptake and increased coverage of the vaccine, there is massive reduction in the incidence of these infectious diseases. And actually, There's been an economic calculation of that, like vaccines are the most effective public health measure to prevent infection. So for any country that spend $1 on the immunization program, they would save an estimated of $10 on treating these infections. So there's an economic value there in implementing vaccines at high coverage. Another example is also measles and pertussis, which is also part of the pediatric vaccination regimens. And again, the high vaccine coverage is really important for keeping the incidence and the cases very low. And unfortunately, lately in the past few years, the vaccine hesitancy has been leading to reduced uptake of measles vaccine, and outbreaks are associated with that reduction. And we could see that the data from the CDC, and the rise is still going, and it's associated to the vaccine hesitancy issue and reduced vaccine coverage. So why vaccine coverage is important? It's to create the herd immunity effect. And I'm going just to simplify this figure briefly. When we talk about herd immunity, we are talking about the immunity of the community or the public. So for example, when COVID hit us, none of us had seen this virus before. So globally, we are all naive to this virus. So the first index cases get here. Most everyone get infected through the transmission and exposure. If some are vaccinated, as the yellow subject here, everyone else get infected, but the yellow subject vaccinated would be protected. However, if we have high vaccine coverage, most of the population is vaccinated. When you have infection, red cases, the susceptible ones are the non-vaccinated. So that explains the concept of herd immunity and the community protection. But just to take you quickly through how these vaccines work, you know, it's a biologic that developed and given as an injection, soon would be given as skin patches in the future, and it could be given oral or intranasal, depend on the type of the vaccine. But how does these biologic work? It mimics the infection, but it does not cause infection. In our human body, we are born with innate immunity and we acquire adaptive immunity. We develop that part. So what is innate immunity? Is the white blood cells and the immune cells that you have circulating in your system. Once they see the infection or the pathogen coming, they activate non-specifically but very fast and curb the pathogen and catch it. And then they communicate with your adaptive immune system to say, we captured an invader, please develop a response. That response could be antibodies or humoral or cells, another specific effector immune cells that would remember that infection and activate once more upon exposure. Without going through details, your immune cells are your guards. They capture the pathogens, they cut it into pieces, they select the vaccine antigen pieces that stimulate the adaptive immunity to produce the protective immune response. Recently, you heard the term mRNA vaccine. This is the latest type of vaccines that have been introduced, and what an amazing success for humanity, because there have been an attempt on developing these vaccines for HIV since 2012 and still in the clinical trials. But right now, COVID made it possible to get this mRNA vaccine. It is not the virus, it's just the genetic code, the RNA code of the spike protein of the virus that get encapsulated in a lipid particle to protect it because it's a very fragile, and then get given in a shot. Once the immune cells takes this particle, they release the RNA. The RNA gets translated to a protein. That's the vaccine antigen. your immune cells would make immunity against it, so that's how you get protected. But if you ask, why do we need booster doses? Once you get a primary infection or a primary, the first dose of your vaccine, your immune system would respond and you would have detectable amount of antibodies, but then it declines, it wanes off. Once you take the booster, that response gets significantly amplified and you will have sufficiently number of antibodies that would be circulating and protecting, and all the memory cells that will remember the infection and launch again and protect in case of exposure. So boosters are really important in the concept of vaccines. Okay, so we have the pandemic, and you could see that so far, unfortunately, more than 255 million cases with more than 5 million deaths, and it's still rising. And we're lucky to have all these vaccines developed without shortcuttings, without affecting the safety or immunogenicity in all these vaccines. So they went through the protocol of safety and efficacy exactly like any other vaccine, except because there is a will, a governmental support, a need, and the technology were already present for the mRNA vaccine. It was just tailored to COVID, so we had these vaccines. If we look at the implementation of these vaccines on controlling the disease, of course, this is the curve for Qatar. Qatar is now considered from the top countries that has the highest vaccine coverage on the level of the population. We are at 85.1% of the people who received vaccine, and luckily we are in good shape with the epidemic in Qatar. Of course, a huge number of people being vaccinated, and the third dose is running now. Hopefully it will stay like that. If we take another example, the United States. The United States took the lion's share of the number of infections, and the numbers are astronomical, of course, compared to Qatar, but they implemented the vaccine, and now the vaccine uptake is increasing, but still, we're at only 59.1% coverage, including the third dose is rolling. So higher vaccine coverage would control the disease better. We take a third example. You have Germany, for example. Right now, unfortunately, they're going through a massive peak of resurgence of COVID in Germany, and we don't know when the peak would decline, but the uptake for the vaccine does not seem to be at very high level. They have like 67% of the population are vaccinated, but the measures weren't as strict. So apparently, if you're vaccinated, you are exposed to get infected and you will transmit the disease, but it protects you from severe COVID and protects you from hospitalization. Unfortunately, it does not protect you from catching the infection. So that's the problem. The restriction has to be accompanied with the vaccine coverage as well. A last example here, Israel. They vaccinated the population at 62% or more. They controlled the epidemic very well in summer, and then they let off with all the prevention measures. They removed the masks, they allowed gatherings indoor, and the summer was the season for all the party and weddings, and it led to this massive third wave in Israel. So they immediately included the third dose, and the third dose did what it do. It reconfirmed the immunity at the population level, and now the disease is under control. Okay, now how did this thing happen, the vaccination, and who did what? Actually, it's a teamwork. It's an interprofessional teamwork. To reach the level of having this high vaccine coverage, it's not just a government decision. It's not just guidelines and policies. It's not just by suggestions from the WHO or guidelines. it's all of you. It's the interprofessional team that actually works in this field and provide healthcare. And needless to say that basic science was heavily involved in the process of, as any vaccine, the basic discovery and proof of concept studies, and then the manufacturers like Pfizer, BioNTech, other companies, but then the implementation of the translational phase, the clinical phases of testing the vaccine. Between Pfizer and Moderna, there were 74,000 participants in the clinical trial in phase 3. Whom you think ran these trials? Nurses, educators, healthcare workers, physicians, government supplied all the resources. So it's a teamwork to reach the conclusion that these vaccines are safe. The clinical trials are speaking to the safety and efficacy, and then it went through the regulation. So now it's time to deliver vaccines to the population, and countries started to purchase their vaccines and start implementing to the public to start the immunization program. As I said, this is a whole teamwork. We started by scientists because they bring the concept, like this is the antigen for the vaccine and this is all the proof of concept data. But then you have to go through all the participants in the process of delivering the vaccines and the uptake of vaccines. A very important role for, of course, the community and public health and the health educators who educate about the value of vaccines. A very important role for the vaccine advocates, the people who understand the necessity of vaccines and how these vaccines work to protect the collective good of the community. And of course, very important, the role of celebrity. You know, with the COVID, the misinformation pandemic that we have, and all the fake news that associated with what is COVID and what is this corona and all the mess around the vaccines, it created mistrust. So we still do need celebrities who understand the value of giving the accurate and good information to restore trust and confidence. So social media influencers and celebrities are also part of this team. The issue that we really face in the world of vaccinology is a legitimate issue. It's vaccine hesitancy. And vaccine hesitancy, actually, it's not one single thing that you could put in one class. Vaccine hesitancy is a range because some people would take the vaccines, but they're concerned. Let other people take it first, then I will take it. Some people, they're just hesitant because they worry about it has RNA, oh, that's nucleic material. So there's some reasonable thinking that goes beyond these type of hesitations, and others are more selective for whatever reasons. But I think the least number of the people on the vaccine hesitancy scale are the anti-vaxxers and the vaccine deniers, and those who refuse the vaccine for whatever reason. But unfortunately, because those limited number of people, they managed to get access through whether power, politics, or platforms for transmitting fake news, they seem to be creating a lot of mess, if I may say, and creating a major hurdle for delivering vaccines to the others. Nevertheless, there's techniques, and studied even before COVID, how successful immunization program could tackle the vaccine hesitancy issue, because this is not a new thing. And as I said, it's something legitimate. Most of us would question the need for the vaccine before they even consider it, right? So systematically, it's being looked on like you have to have confidence in the vaccine. So the confidence allows the public to trust people, policymakers, if they trust them, non-corrupt government, not thought it's for profit. All these things give confidence to and trust into the vaccine. And also the availability. Luckily, Qatar is a leading example where there are, and every PHCC almost, they give the COVID vaccine and they give it for free. That's just one example of many, many other vaccines that are provided easily. So it's accessibility and availability and all the incentives that comes with, if you take the vaccine, your ihtiraz changes color, you're allowed to sit in a restaurant, etc. So these things help. There's an important concept here, which is the collective response. We as participants or member of this community, do we care about our own self or the collective responsibility towards the community? And in fact, if you look at most communities, they do care about the health of the community. Most people are accepting their vaccines because they want to protect their grandparents, their elderly, etc. That's a sense of collective responsibility towards the community. Of course, complacency and other reasons that might help tackle this, but you need interprofessional team to educate the public to tackle and implement vaccine hesitancy. As I said earlier, we don't, I didn't say earlier, I say it now. We do not fight with anti-vaxxers because the argument is the gap is way too huge to bridge. So your argument should be just show data, show infographics, show by scientific facts how vaccines works, how it protects the community. Of course, each one of us has a role to play in this. In my role as a microbiologist, I could ease the fear of anyone who's worried about the nucleic acid vaccines. And why? This mRNA is so fragile, will not reach your nucleus in the cell, will not integrate in your DNA, and will not change your genetic makeup. This mRNA will not create any more adverse events than what you see in many other vaccines that we've been using for the past 80 years. The health policy makers and the public health experts, they have a very essential role to play in tackling vaccine hesitancy, because if the leaders go and show their shots, they're already a vaccine advocate for the importance of this. If they provide the resources and the facilities and the tools to help facilitate the vaccine uptake, this is very important. Public health experts, they're very essential in the COVID pandemic because we're following how they're showing us the pattern of disease and when to lock down and how to lock down and how to prevent the consequence of this. Nurses, I love nurses because they do the great job of touching the patient, treating the patient, doing everything with love. And I don't think they get enough of the respect that they do deserve. So nurses, if you're listening, we love you and appreciate all your work and the hard work that you do. But the nurses are the ones that inject the vaccine, and it's beside the other things that they do, it's very important that they understand the value and how to talk to the hesitant, educate them about it. Pharmacists, it's a big role that you understand the composition of the vaccine, the immunogenicity, the safety, and how all these formulations are made. It's thank you for making this happen. Our physicians, of course, the White Army is just like you're the leader of the White Army, and without you, we will not be doing health, doing well. So being the decision maker at the top of the pyramid, if I may say, your role is very important in advocating also for the vaccine coverage. For the biomedical lab technologists, you measure our immune responses, you report our data, you take care of all the information that we need to show the vaccine works, and here are the data. Health educators, absolutely essential role, whether on social media platforms, whether at the community level, whether in schools, in clinics, wherever. Health educators are very important in transmitting the confidence in vaccine and giving the correct information through infographics and through data to the public. Vaccine advocates, of course, needless to say, we've seen many good examples of them, whether from TikTok or social media. They're really doing an awesome job to help the vaccine coverage uptake, and celebrities as well. They do a great job. So I'm going to end here by just summarizing that implementing protection in the community through the immunization program literally takes an army of people, and at the healthcare, the interprofessional healthcare providers, in addition to the community participants and celebrities, are really to be thanked for that. And for all of you, thank you for keeping us safe at the level of the public. So I'll stop here. If you have any questions, I would like to answer.
Thank you, Dr. Susu. Thank you for this presentation. And I can see you are a scientist, you know, providing a lot of the background behind, you know, the vaccine development, and sharing with us some of the, you know, the key information about the vaccine and, you know, the vaccine coverage and so on. I think somebody has raised their hands.
Yes.
Any questions?
Yeah, Assalamu alaikum. This is me, Dr. Farah Mansouri here.
Yeah, please go ahead, Dr.
Okay. Yeah, so nice to learn from you, Susan. Just one question, being a public health physician, coming to my mind, that in this era of pandemic with so much misinformation and disinformation, how you tackled or who were actually the actors in dealing with this vaccine hesitancy, particularly in your own scenario?
Right. It doesn't take one person, it takes an interprofessional team. So as I said, not a single person could address the vaccine hesitancy issue. But if we start from, for example, from the WHO, they issued all these very interesting infographics with data that helps explain the concept of vaccines and the safety, you know. By now, when the World Health Organization tells people that there's more than 7 billion shots of vaccine being given to people, where most of us still alive, you know, so we didn't die. And it started from like the higher authorities giving this documents that help everyone else to use these facts, these data. The physician has very important role to inform the vaccine hesitant patients about the risk of not being vaccinated on the long term on their health. Every member in the clinic or the vaccination center or at the university or wherever you are at the workplace, everyone has the collective responsibility, if they understand and know the subject, is to speak about it. And as I said, the vaccine advocates, actually, you've seen probably on Twitter, the very first time His Highness Sheikh Tamim got his shot, it was publicized. And that was actually a very smart move, because there were a good number maybe of elderly who are hesitant to take the shot. But when they see the Emir himself is not afraid of this shot, that means it's safe, and that's encouraging. That's just an example. And when you have a celebrity being followed by 2, 3, 5 million, whatever, on TikTok, and they advocate for the vaccine and they say it's safe and whatever it is, that's also the message that should go out. So Whose
Yes.
responsibility? It's a team responsibility.
Yes. Okay. Okay. Thank you.
Welcome.
Mm.
You're muted. Taysir, you're mute.
Thank you so much, Dr. Asusu. Yani, you set a role model example of how a team can work, and you do it with love always in every encounter. So thank you so much, Dr. Asusu. Now, I was wondering within that, the team, I understand the role of like health promotions and like, health educators. And I'm wondering if within that category, we would like, as psychologists, within, I'm not trying to promote us, but I'm just saying that we have a very important role, especially when it comes to the hesitancy and working with behavioral change and motivation interviewing. And I'm wondering to what extent that was kind of considered within that category.
Yes, absolutely. Thank you. It's a very important point, but it's on the category of health educator. I lump that because there are many people who would contribute so significantly to tackle vaccine hesitancy from their place. So you deal with, from your point of view as a psychiatrist or psychologist, you talk to your patients, that helps a lot. A teacher in school could be a health educator when it comes to not just healthy diet and nutrient. The teacher plays an essential role in educating students in the class about the importance of the vaccine and teaching them how to sort facts from factoids or these misinformation circulating all around, like, the WhatsApp leading the vaccine hesitancy. It needs some good educators to teach young generation in particular how to sift through what's factual and what's not. And of course, it needs expertise. A lot of people, they just send messages. Can you please tell me, is this video accurate? Until this very day, I've been responding to a lot of messages about all these fake videos that doesn't contain actual vaccine facts, but it's factoid, I call it. Like, they present very little part of what seems to be accurate, but it's so filled of wrong information. So that's what we need to train the people to distinguish the content and follow the facts. That's why I will never argue with someone who denies the vaccine for any reason. I just present my facts and I stop there. Right. Dr. Ala, you're mute.
Dr. Farah, do you have another question? I see your hand raised.
No, by mistake, I think that was done. Sorry.
Okay, no problem. Dr. Suzanne.
Thank you, and thank you very much, Dr. Susu, and thanks for sharing with us a wonderful exemplar of amazing efforts to protect your community, which is fabulous. I was just thinking, could share your email with people that I talk to about vaccine hesitancy?
Yes,
but probably that would. I'm just kidding. Don't worry.
Yeah, no, don't worry. I'm open to that. No problem.
That's very kind of you. Yeah, just I'm interested in, like, perhaps other people might also contribute to this conversation, because we've heard some great examples of teamwork. And I guess what I would like to understand from our speakers is, what is it about teams working together that makes them interprofessional? What is it that you have found that differentiates the multidisciplinary team that works together, knows their roles, complements each other, compared to the team that we're talking about that is learning and working together, what is the secret sauce, the differences that you would, try to support students and practitioners to understand about that?
From my perspective, as a faculty member at one of the QU Health colleges, I think it's very important for our medical students to know that they're not the only players in town, and all other colleges graduates are equally important for the health and the prosperity of the society. Not to undermine the role of the physician, not at all, but it's just to open their eyes about the very essential and critical contributions of all other team members into delivering the outcome, which is the health of the community. So I think working as an adult faculty with interdisciplinary research team, we don't have these issues because we know that each one has his or her own expertise, and we complement each other, and we come up with a result a result of all our brains together to bring this fruit to the table. But when we think of IPE as education of interprofessional, what we teach our medical student is different than what the pharmacy are teaching their students. So when we talk about vaccine, we probably teach them about how the body respond to this antigen, distinguish self from non-self. But the pharmacist would tell them how exactly these become a product, and this product is a formulation, and what would it take when you become a physician and you see this vial, you would know how many people work to get it to this level. Same thing for the nurses. As I said, the nurses, they're very essential in handling the patient firsthand, because they're probably with the physician are the most people who touch the patient and who really care immediately with the patient. What the techniques they learn and develop on how to handle the patient is something that we need them to tell our medical students and other healthcare providing students how to learn from those who are firsthand touching and dealing the patient. I don't know if I answered your question, but I tried.
Thank you, Dr. Sousa.
You're welcome. Dr. Anna, you're mute.
It's the saying of 2021, isn't it?
Yeah. I was just saying, maybe Dr. Guinome, you can also, contribute to the discussion and, answering the question Dr. Suzanne raised about like how to ensure that, people are really interprofessionally working together. Like I know sometimes as, there is a differentiation between multidisciplinary teams and then where everybody knows their role, and yes, they're interacting with each other, versus interprofessional working, where people are really collaborating, understanding their own limitations, understanding, clarifying the different roles and responsibility. There was another part to your question, Dr. Suzanne?
Yeah, no, I guess it's about how do we relay that to the students, because, as Dr. Sousa said, yes, we all have different discipline knowledge, but there are some things that, like you've alluded to, about understanding the role of others, and I would say also understanding the experience of the patient. Some of those things are common to all of us and help us to collaborate in healthcare. So I guess I'm just thinking about that as we're, involved in this area of interprofessional education, how we can really help students build those collaborative competencies. What is important to emphasize.
Yeah, I think it becomes really interprofessional when they are not just following one, who may be the most outspoken student in the group, but really becomes teamwork and interprofessional if they all share their different perspective from their professional point of view and make suggestions and explain from their own perspective. Otherwise, if there is an activity which is led, let's say, by a dental student, and we've got all the other allied health professions, and they're just following, they're not sharing their own perspective, that dental student is not going to learn anything from the others because they are just leading and the others are following. So it really, for it to be interprofessional, they all need to bring their piece to the puzzle for everyone else to learn about their professional role and their perspective.
Thank you. I was actually, yani please anybody can chip in and answer. Like just going back to the vaccine hesitancy, I'm just thinking like how, like Dr. Susu, you've highlighted, the role of each profession towards COVID or even vaccine hesitancy in general. Their specific roles and how they can contribute. But I'm just thinking, like, how can interprofessional collaboration, both in education and practice, support strategies steered toward vaccine hesitancy? How can the team really work together?
Yeah, I think it's the team could work together in developing a narrative, a consistent narrative that based on facts and data with evidence. And when you have a team narrative that's consistent, built by input from different learners or disciplines, then in any form it would be transmitted. It should be transmitted and distributed as the narrative of the IPE or the interprofessional team. And when you have all those people agreeing on this one very carefully crafted narrative that's based on facts again, I think that would put the confidence in vaccines and increase the acceptance rate and the uptake as well. Because isn't the opinion of one person or one representative, it's the collective opinion of the team.
Great, thank you, Dr. Susu. And going back, Dr. Gnome, to like you mentioned, it was very interesting how staff select their own projects. And you mentioned, these are submitted maybe to the team, to the committee to look into these, to approve them. What kind of criteria do you look into this? And do you look like, for example, on the interprofessional nature of these projects? Are there any specific domains that you really focus on?
So we want projects, that are going to be meaningful for the service, for the organization, and for the patient. We don't want them to, because it's a significant time commitment for the team involved, but it may also be a significant time commitment for the business intelligence team, who may need to retrieve data. They may also involve additional colleagues to help them collect data. So we want to make sure that people do not waste their time. We want to make sure that the staff that we recruit are truly committed and, don't just want to do it to, sit back and collect the CPD points at the end. So we really want them to be, owners of the project. So that's why usually it's better if we let them choose rather than us trying to propose. But, we have to consider, whether it's a valid project or not, whether it's feasible and whether it's going to be beneficial, for the service and for the patients, whether it's directly or indirectly. So these are some of the key points.
Great, thank you. Dr. Suzanne.
Yes, Dr. Guillaume, I just wondered if in the education that is scaffolding around the projects and quality improvement, Do you do any exercises or activities that are related to building teamwork at all?
So I'm not involved in the I've attended many of the HHQI projects, and I was usually even chaperoning the first 4 or 5 teams that we've involved in, and I was actually going to the sessions myself. And they do take part in. They've got lots of great activities. They've got videos, but they also do hands-on exercises across the whole room, trying to improve processes, where they're given constraints, and they do something about patient flow, and then they have given an additional right thing to privilege to use in trying to improve, and then after they can make their own improvement. I mean, it's a very engaging course. It's really a workshop. It's very active. So it's a great learning, and there's a lot of team building activity as part of those days. So I've got I know we've got colleagues from PHCC there. Some PHCC teams have done it. Encourage more and more people to do it. There is limited capacity. I think I mentioned maximum they were doing. I think might have been pre-COVID was 70 in total, up to 15 teams in total. I don't know right now. I'll speak to my colleague tomorrow as to how many people there was in the room. But I think the teams were smaller. I think the team we've put in this year, there are only 3 or 4. Whereas in the past, we've had teams of up to 6, 7.
Fabulous, but hopefully things will, get a bit more dynamic now because of the situation. Yeah, so that's wonderful to hear, and so important in being able to complete well project-based activities. I guess I just would say to you, maybe along with the certification for being QI champions, perhaps talking to your colleagues about emphasising the interprofessional and collaboration aspects of what people are doing in learning about each other's roles and improving processes for the community. So, yeah, it sounds like there's lots of potential there to make that a bit more explicit as well too.
Yeah. Yeah, I think I think in quite a lot of the things there is a lot of multidisciplinary working that really happens, and I think I agree with you, Suzanne. I think just trying to make that explicit, focusing on the principles of interprofessional working, the teamwork that needs to happen, is of quite important, and try to having that from the beginning. Like I know Dr. Suso, she really emphasized on the role of the different professions. And I know in the IPE activity that we do with the students, one of the things is, okay, how can we work together in a team, to talk about COVID hesitancy, even sometime maybe developing these messages together, everybody thinking about it from their different perspective. So yeah, sometimes I look at it even with patient safety. Everybody thinks, yes, we are doing patient safety, and it is implicit within our working, but sometimes it needs to really be highlighted so people, look at it, from a different perspective. Okay, any questions from anyone? Any comments, on these really great presentations? I think Dr. Mohammed, I think we lost Dr. Mohammed somehow.
Yeah, I think he said he had to go to clinic.
Okay. So yeah, any questions? Any final comments from the speakers? Like, thank you so much for joining us today.
I want to say something. I learned new domains that I am not very familiar with today. So the more I participate in these IPE events, the more I learn about the dynamic of thinking and goals of these activities. And I truly appreciate it. So thank you, speakers. I learned from you.
Thank
No,
you so
thank
much,
you.
Dr. Susan.
No, thank you for the opportunity. It's great.
Thank you, and we hope we will be able to present during the Altogether Better Health in 2023, inshallah. And thanks a lot for everybody who has participated in today's webinar. I'm just going to share again my slides just to let you know about the upcoming presentation. So this is going to take place on the 29th of November, the same timing, so 12:30 Qatar time, 9:30 GMT time. We have Dr. Ahmed Al-Hammadi from Sidra Medicine, Dr. Lulu Mahmood from India, and Dr. Subraya Nambir, also from India, talking about different topics related to interprofessional education. So we're very much looking forward to this. And we hope to see you next week, inshallah. Dr. Suzanne, do you want to say any final words?
Yeah, just thank you so much to the speakers and the audience. As Dr. Susu said, we always learn from each other, and it's a wonderful opportunity to do that. And yeah, I commend the speakers on their projects. Really, really interesting presentations. Thank you.
Thank you, everyone. Have a good afternoon.
Thank you.
See you next time. Bye-bye.